We are going to get started now that it's 9 o'clock. This is just another friendly reminder to mute yourselves if you've joined in the next little bit and haven't heard my consistent reminders. Sorry about that, everyone. Anyway, so we'll go ahead and get started. This is Jessie Hassler from Better Health Together, and we have Dr. Corey Waller with us from Health Management Associates, and he is going to walk us through the opioid crisis and how it pertains to the Medicaid transformation and what our work is going to look like. So with that, I guess, Dr. Waller, I will hand it over to you. And if people can hold on to your questions until the end, we will have time for that at the end. Thanks, everyone.
Great. Thank you so much. And just by way of kind of who I am, just so you know the frame that I bring to this, I'm Corey Waller, I'm a principal at HMA. I just started with them actually this month in June. Prior to that, I'm a physician, board certified in emergency medicine, addiction medicine, and pain medicine, and have spent really the last decade working on not just opioids, but addiction at large, as well as chronic pain, and more importantly, kind of building out the systems of care around all of these things so that we can create an idea of what we should be doing from one time to the next. And I found along the way that really there's a bigger element at play here, and it's not just about addiction specifically, but it's really about the total cost of healthcare, that it lives around that 5% that costs 50 to 60% of healthcare dollars. And today I'm going to walk you through a little bit of what I call the sentinel syndromes to show you why setting up an addiction treatment system or line of service is really important. And then we'll talk a little bit about addiction as a disease so that we know why this system works through kind of the neurobiology and the science of this. So that's what I will hopefully get through and then be able to answer some questions by the end. I can go to the next slide. I do want to remind everyone that we're really good at treating the effects of things rather than going at the cause. So keep that in mind, that we want to start treating the causes of the patient-based conundrums more, we want to get to the base of it rather than just putting Band-Aids on the effects. Next slide. I don't have any disclosures. I have nothing and never have from pharma, device, any of those things. So clean bill of health as far as that's concerned. Next slide. So this is a kind of a map of where we all start, right? We're all given this basic genetic deck of cards that we're born with, and that genetic deck of cards for some of us has a few extra jokers and some a couple of extra aces, and then that's even influenced a little bit by some of the epigenetic changes that happen during our in utero phase, and all of that ultimately just sets the plate for what we have as potential. However, one of the things that occurs in patients that end up being that 5% that costs 50% of healthcare dollars is significant early life trauma. In fact, it's estimated that greater than 98% of people with a substance use disorder meet for moderate or severe ACEs, adverse childhood events. And that could be anything from directed physical trauma, emotional trauma, the most pervasive one, which is neglect, sexual trauma, and those things completely change and reset our genetic risk. And with that genetic risk, we start to lose whatever positive capacity we had, and we've chipped away at it to the point where if you have that early life trauma, that adverse childhood event that occurred, and whether that's repetitive or a single event, then you get this decreased buffer. And that buffer is both in the emotional capabilities of your brain to be able to cope with these different emotional settings. And then you get this innate feeling of a decrease in safety. That alarm bell is going off more commonly, that anxiety and fear part that lives actually in this lateral bed nuclei of the amygdala. So we know where in the brain it is. And because of that, you're not really able to build these authentic healing relationships, which are the things that are required to feel included, to feel as a member of society, and really to make it not look like we see in the experiments that look at isolation. And it's the old wire monkey and carpet monkey mom stuff in psychology back in the 60s when they looked at, you isolate it, and you get a completely unhinged development, and you can't create normal attachments. And normal attachments are what are required to be able to connect with other people. And after we've had this happen, this leads to an increased risk of really what I've called the sentinel syndromes. Next slide. And this is after evaluating a number of about 300 to 400 health systems and clinics and thousands of patients through this. I ran a clinic dedicated to patients who were in the ER 10 or more times per year or pregnant on a controlled substance. And what I found is that really there are four drivers, or four syndromes that drive that high cost in these patients. And those four are addiction, mental health, chronic pain, and cognitive impairment. We could mute the line with the, I guess it was a dog, we'll see. And so we have the addiction and the mental health, chronic pain, and cognitive impairment. And with these, what we end up with is a setup for a lot of downstream effects. Next slide. And so this increased risk of homelessness and incarceration occur with these four things. And then when you have homelessness and incarceration, then what that does is that it sets up this inconsistent transportation, unpredictable communication, and lack of care coordination. And all of these have been identified as baseline risks for bad outcomes for patients who have all sorts of diseases. But we end up treating the diabetes and the COPD and the hypertension, the CHF, rather than the drivers of those being uncontrolled. Because there are a lot of people who have diabetes or hypertension or COPD, but only a small percentage of those are expensive, and only a small percentage of those utilize the system at a high rate, and that disproportionately sits within the Medicaid world. And so when we look at what we're trying to do, we're really just trying to take all of these diseases and start moving up the ladder. And we've done that a little bit by setting up better transportation. Was that a goat? That's interesting. So to move up the ladder of what we're doing to take care of these patients and get to the point where we deal with the sentinel syndromes, and at the end product, really get down to where we're dealing with early life trauma. I mean, that's the ultimate goal. But we have these four syndromes that we don't have systems built for. And today I'm going to focus on addiction and kind of why that is really important. Next slide. So we need three things to survive. Next slide. We need food, water, and dopamine. Next. And some people will say, the persnickety ones will say, okay, we need oxygen as well, right? Well, we need skin, but we're going to focus on the other three things, the food, water, and dopamine. And we need these to survive, ultimately, because these are the drivers that make us get up in the morning, get a glass of water, eat some breakfast, and move on. But even to get up out of bed in the morning or to create relationships, we require dopamine. So dopamine is this chemical in the brain that is responsible for how connected we are to society, how connected we are to individuals, how we create a mother-baby bond. When somebody pats you on the back and says, good job, it's the chemical that gets released to make you want to do an even better job and create motivation. And so whenever I say dopamine for the rest of the webinar, I want you to think about motivation. And when I say motivation, you should be thinking about dopamine. And this is important because it is the base chemical that drives us to get out of bed and get those basic things done on a daily basis. And we've even studied it enough to understand how much of it is roaming around in a part of the brain responsible for motivation or reward, and that's this area of the brain called the nucleus accumbens. And what it is that 50 nanograms per deciliter, Elliot Gardner at NIDA found was kind of the baseline amount required to get out of bed in the morning, go get your cup of coffee, get into work, and then sit down and listen to a webinar at 9 a.m. on opioids. And that amount of dopamine is required. Your worst day ever, like the day that you call in and you fake vomit on the phone because you say you're sick and you don't want to go in, where you sit at home in your pajamas, you don't want to leave or do anything, that's about 40 nanograms per deciliter. And then we have like the best day ever, you know, the day you win the lottery, have 2% body fat, and own an island all at one time. And that when that happens, that's about 100 nanograms per deciliter. Best food, your favorite food, is about 94 nanograms per deciliter. Sex is about 92 nanograms per deciliter. Bummer, but oh well, that's just the way that the research crumbles. And when we start to look at this, that's where we're supposed to live. But what happens in the case of addiction, in the case of a drug or an addictive behavior like gambling, we get a disproportionate release of dopamine for a small reward. And that disproportionate release of dopamine is not a little bit more than 100, not even a lot more. It's catastrophically more than 100. It's 1,100 nanograms per deciliter. It is over 10 times the amount of dopamine that the brain should be producing when somebody uses methamphetamine. And it's, you know, in the 900s for heroin and 700s for alcohol and marijuana and nicotine. So it is way up there. And what that does is it creates the body's situation where it's going to fight back. Next slide. And if we look at what ultimately we have, the baseline is where we're supposed to live naturally. Best day ever is supposed to make us motivated to want that again. But when we have this disproportionate stimulation of dopamine in our brain, the brain says no more. In fact, it says it instantaneously. So the first time that somebody uses a drug like methamphetamine, the body will turn down the dopamine production permanently. And it's not going to turn it down a lot at that very beginning, but we hear this term in patients with addiction that they use called chasing the dragon. And they say they were looking for that same feeling that they had the first time that they used. They're never going to get it again because immediately the brain dialed down the amount of dopamine that was there. And if you continue to use, it will decrease it further. And if you continue to use more, it will decrease it even further. And then if you continue, then the body will shrink the nerves. And then if you continue even past that, there's good data to show that the body will even permanently kill off those neurons that are responsible for the reward system. And that is really important because that is permanent. That is like having a stroke in the happy part of your brain. And so as we look at what occurs in patients over time, we find that we have very identifiable structures in the brain that get injured many times permanently in some patients that have been using for long terms. Next slide. So when we start to look at these, different places, if you can click forward about 4 times. One more time. If we look at these areas of the brain that are responsible for kind of reward and interpretation of pain, these are the areas that we can find on a functional MRI that help us to understand what is going on with the patient. And in fact, we've used the identification of these places to help to understand craving and why someone would continue to use a drug even after they've been off of that drug for a while. And there were studies that were done that looked at patients' brains, and we looked at people who didn't have any food for 5 days. They got IV fluids, but no food for 5 days. Didn't get water for 3 days. And then we would put them in the MRI, and then you would have the person who didn't get water for 3 days, and they would put them in the MRI, and they would play water sounds in the background. They would be like flicking water on their feet and have them talk about swimming. And then they would image their brain to see what areas lit up and how much. And they found that craving, it was about the relative size of a baseball. And then they looked at the patients who were food deprived, and that had been for 5 days, nothing orally, and they asked them what their favorite food was. They had them describe it. They even brought the food in the MRI and kind of wafted it into the tube so they could smell it. And for that, they found the area of craving around food was around the relative size of a basketball. And then they did this with patients who had been detoxified off of their drug of choice for 30 days, 90 days, 6 months, 1 year, 18 months, and 2 years. And they looked at their brains, and they asked them to talk about the first time that they used the drug and the last time that they used the drug. And I'm only going to really talk about the 30 days and the 2 years because we found that there wasn't much change in that craving switch for up to 2 years in most people's brain. So at 30 days, when they looked at this and they had them ask those questions, the relative size of craving was not the size of a baseball or a basketball, it was the size of a baseball field. And so the craving that the brain has for the drug of choice / dopamine is an order of magnitude bigger than the craving that's in there for food and water. And we know that people will do crazy stuff to get food and water, right? They will, if you walk across the desert for 3 days and you don't have any water and you get to the other side of the desert and there's this beautiful glass of water sitting there and it's got condensation coming down the sides and you go to grab it and somebody steps in front of you, you're going to be like, oh, okay, and I'm going to stab them right in the belly and I'm going to move them out of the way and then I'm going to take that glass of water because I need it to survive and they shouldn't have gotten there. And actually outside people would see that as, well, that guy probably shouldn't have stood in front of him. And we'll let people steal when they're starving. And we'll say, well, they're starving and we can see why they're looting the grocery store to get food and survival. And we're okay with that. But imagine that motivation being 10 times higher for getting dopamine and specifically the drug of choice. And so when we look at these parts of the brain and we see this massively disproportionate survival drive to get a drug of choice, this starts to really help us to understand the disease of addiction. Next slide. And when we look at it, we look at the behaviors that we see in these patients, and a lot of times those of us who work clinically and see patients on a regular basis, I still work clinically in the emergency department, and so when people come in, you see some behaviors that seem a little out of whack. But if you think about the neurobiology that we just talked about, you have a patient who has a lack of dopamine, which causes this really massive amount of craving that flips them into survival mode, and then they have a primal action, and that primal action may be stealing money out of their parents' purse, robbing a store, coming to the emergency department and screaming at the top of their lungs that we're not treating them for their pain and they need Dilaudid and they need this. It may be that behavior, but we shouldn't really be surprised by this behavior. Next slide. Because when we start to look at how we diagnose opioid use disorder, we diagnose it based on behavior, right? We don't diagnose it based on a lab test. We diagnose it based on that the patient has impaired control of the drug. They have social impairment because of trying to get the drug. They have risky use, which increases their chances for things like overdose and HIV and hepatitis C and infections. And only 2 of those are pharmacological properties that put them at increased risk for having addiction. But if patients have been written for a prescription for opioids, then these are not even helpful because everyone who's been written a prescription for opioids for pain has both tolerance and would withdraw if we stopped it. So when we start to look at it, this also will help us to understand kind of the pathway of treatment for these patients. Next slide. And this pathway of treatment really is, based on assessing the behavior, and that aberrant behavior has to be expected. And we should start seeing behavior as a symptom and not a frustration. And so that person who shows up to the emergency department or to the office or, for a crisis evaluation, that behavior, the worse it is, should be ringing bells no differently than if a patient had an abnormal EKG and chest pain. The worse the behavior, the worse the disease, which means that we need to start evaluating how it is that we restabilize dopamine so that we can get this patient to fully understand what situation they're in and start to make decisions based on a logical matrix and not just survival and instinct. Next slide. So if we look at the treatments for this is why the treatments work. And if we have this lack of dopamine that's the problem, and this lack of motivation, then what we would want to do is augment dopamine. We do this for serotonin, and we don't think anything of it. But when we look at what we're going to do to augment dopamine, we've really found 2 things that out of the gates help to augment the increase in dopamine, stabilize the patient's behavior, pull them out of that survival mode, decreasing craving, this allows us to actually have appropriate therapeutic intervention with patients from a behavioral standpoint. The old legacy treatments that have been around for 70 years, they just don't work for opioid use disorder. So the reason that they don't is because if you don't have dopamine production that's adequate, then you actually cannot onboard new emotional memories. It's a requirement to have dopamine to onboard a memory. Think about your strongest memories. There are those with fear, and then there are those with happiness. And dopamine plays a part in both of those. So if you don't make dopamine at the right amount of levels that you need in the central brain, then you're not going to onboard emotional memory. And emotional memory is also known as therapy. That's what we're trying to do, is to get them to onboard a pathway to change their emotional capacity at the same time that we're working with them in other places. But if I push them just into an inpatient facility and then tell them to go sit in group and their dopamine level is subtherapeutic, all they're going to hear is rah, 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 rah. They're not going to get anything. And then it creates frustration for everyone. Not only even the therapist delivering the therapy who said, we went over this the last 3 times, how are we not grasping this and why is this so hard? Well, it's hard because they can't actually form that emotional memory. Next slide. So if we're going to look at how we're going to vary the treatment, we have to come from the basis of the neuroscience, which is we need to understand that we have to stabilize dopamine. Generally speaking, buprenorphine and methadone have the best data. Buprenorphine has well over 100 publications for utilization. Methadone has well over 1,000. Now, Trexone, which is a Vivitrol injection, still only has about 10 publications. So we're still learning exactly who and where to apply that medication. It's going to have some definite therapeutic value, but the question we have now is, who is eligible for it? When should it be applied in treatment, and to what population? We haven't fully answered those questions with that one, but for buprenorphine and methadone, we definitely have. And so the things that should vary is not access to medication-assisted treatment, but where's the location of treatment happening? What is the intensity of treatment being delivered, and what are the behavioral health interventions? Now, the good thing is that we have the capability to evaluate this really easily. We have the ASAM criteria, which is the American Society of Addiction Medicine's criteria for placement. And we even have an online version of this that when I say we, it's the collective we, but the online version allows you to go in and do a standardized algorithmic question and answer, which would tell you that here's the severity of their illness and here's the treatment level that they match with. And the ASAM criteria has 4 main levels of care. And that is 1, which is outpatient, 2, which is intensive outpatient, 3, which is residential, and 4, which is medically managed detoxification. And there's a lot of little levels in between there. But at the same time, this allows us to appropriately match the right person with the right treatment. And if we look at what we do for other diseases, this is exactly what we do. So if a patient is having chest pain and they show up to the hospital, it's not like we only have a cath lab, that everybody goes to cath lab. It doesn't matter the cause or effect or severity. And we don't just have an outpatient follow-up. So you have to have all of those levels of care for addiction. And that's been a real issue. Next slide. So if we were to think about this picture as being cardiology, right? You walk out of one of these buildings, you look to your right, you have a CHF specialist. You look to your left, and you have a specialist in endocarditis. And then you have a specialist in right heart failure, and a specialist in electrophysiology, an outpatient provider who can write you for meds for high blood pressure and hypercholesterolemia. You have educators for cardiovascular diets. So at the end, you have everything you need. And this is most specialties. This is diabetes, this is cancer. You can generally get access to all of these levels of treatment when you need it. And if we were to look at the corresponding picture for addiction medicine on this next slide, then what we see is what addiction medicine currently is. It's a sheep farm. So what you end up having is a whole bunch of sheep stuck together in one place, like an inpatient rehabilitation, and then they're let go out into the field, and then some of them will huddle together for safety, and others will wander off. Some are going to get eaten by the wolf, and then others ultimately are going to suffer the same fate that all sheep eventually in this situation get. They all get sheared. They're definitely not getting appropriate levels of adequate treatment. And redefining an entire space around Medicaid or commercial payer space, we have to think about what is the ecosystem of care needed to treat these patients. And if you're looking at the ecosystem of care needed to treat it, it is not this. It is the large cityscape that we need. They need to be able to walk out and get the treatment that they need, but they should be matched to the appropriate level so they don't get too much and they don't get too little. Next slide. So if we look at building a system around the syndrome of addiction, it really requires all of these components. And as well as the one that's missing on here is criminal justice, which should probably be the central bullet there. But if you look at all of these, you can see the levels of care that need to be done. We need to have appropriate screening and referral. Less than 10% of primary care is screened for addiction. Less than 10% of OB offices screen for addiction routinely. We need to have data collection and evaluation. This has been hampered in the past with 42 CFR Part 2, which governs protected health information for addiction. But the House just passed a bill that looks like it should move through the Senate and get signed, that rolls 42 CFR Part 2 into HIPAA, which would allow that barrier to go away here within the next few months. And then this way we can start to look at those that are delivering care and hold them to account for outcomes. Because that data has been so invisible, we haven't really been able to do that effectively or efficiently, and that's coming. Social determinants and prevention. I mean, this is huge. So finding people on the front end of disease and preventing a progression of it, or harm reduction techniques of those that have the disease, having access to needle exchanges, having access, to all of the other components of harm reduction like naloxone, and even some of the visualized use clinics where they can come in and use in a safe space. And so anywhere within that is going to help to prevent not only primary but the secondary pieces of the disease. And then dealing with things like felony abatement with patients who, even if they get into remission from their disease, have a hard time finding access to appropriate treatment, appropriate jobs because they have a felony, or even housing because they have a felony. So figuring out how we deal with that. How do we get stabilized medium-term housing for patients as they're recovering from their disease in that first couple of years? What do we do for getting them job training, getting food into an area so that people have appropriate dietary needs taken care of? I mean, those are all huge things. And then we can get into clinic structure. I mean, is it a large-scale clinic with a bunch of everybody who you consolidate into a hub, or is it a hub and spoke? Is it none of the above? Is it standalone clinics at different levels of care? Is it, whatever the structure is, we should be able to figure that out. And then the payment models, again, which is huge, is figuring out how do we pay for a sustainable pathway. And addiction treatment, unlike some other treatments, is really perfect for bucketed payments and episodes of care payments, because patients go through pretty distinct pathways of care and treatment, like induction and early stabilization. And then you have your intensive outpatient time frame, and then recovery, and then even relapse has its own code. So as we look at payment models, there's a way to do this. Was there a question? Nope. Okay. And then treatment education. Treatment education is really centered around everybody doing predictable, same stuff. And this is where it's been lacking in a lot of other areas, because, in addiction, because if they send them to one place, they may get one thing, and another place in a completely different thing, even if it's the same person who meets for the same level of care need and should be offered the same basic tenets of care. And so that treatment education is to level set the environment so that we can all work, in the same predictable manner, and that it's predictable for patients and families as well. Next slide. So the integrated care approach, and this is where it gets really tricky with some of the Medicaid pieces where, not being able to pay for a behavioral health visit and a medical visit in the same day. Having disconnected buckets of care where you have a block grant and some alcohol tax money and some other separated Medicaid money and a grant covered with Medicaid, like when do all of these streams come together? That's the difficult part. And if we can start to consolidate some of those funding efforts for integrated care payment models, then what would allow for us to do is to put all of these people together in a single location so that patients can kind of have the no wrong door and the one-stop, shopping approach. And I think that's going to be the really helpful next step for this in figuring out how we move them through the integrated care piece and know what our next pathways of intervention are. Next slide. So to kind of end it and then open up kind of the discussion phase, we should understand that addiction is a major driver of complexity. And quite honestly, without focusing on it and building out that line of service, we're never going to be able to get on that 5%. We're lacking even the most basic infrastructure of treating addiction in most places. And the frustrating part is we know what to do. We have the data, the science, and the math to back up what exactly we need to do to get these patients better. And now we just need to kind of start doing it. We need to start implementing these programs and connecting them in the right places so that we can create an ecosystem of care around addiction rather than just one-off programs here and there. So with that, we can open it up to Q&A, and I can dig into some of these topics a little deeper if anybody is interested.
All right, I've unmuted to be able to ask questions, but if you're not speaking, please remember to have yourselves on mute just to avoid background noise. Thanks, everyone.
Hey, Corey, this is Ron Stock. Good morning.
Good morning. How are you?
Great. Thank you. That was very interesting. I'm really pleased to hear about the work around the 42 CFR, and hopefully that problem will be dealt with effectively. I was wondering if you could. I have a couple of questions. I'll just start off one, and then others can ask other questions. But I was wondering if you could talk a little bit about family and peer interventions, how that has been kind of organized within either a clinic or a treatment center, and the impact that has. Are there any models out there that these folks could benefit from?
Yeah, no, it's a great question, Ron. Thanks. This is something that is, we're trying to figure out where is the best place to use, what is the right level of education, what is the right amount of ongoing oversight, and who should be responsible for that oversight, because we're really adding a new individual into the treatment continuum. And with that, we need to have an appropriate scope of practice. And I don't think we've gotten to the point, at least at a national level, figuring out what is the perfect scope of practice. We do know, however, that having peer navigators and peer support personnel that are very explicitly trained not to give treatment advice, merely to lend an ear, help them to connect to all of the right pieces. That's the piece that has been helpful, and especially for peer support, if you have someone who is in recovery themselves, it adds a layer of familiarity to the patient as they're trying to recover, and B, interact with someone who kind of, quote, gets it. We do this in many other diseases. We do it for cancer with support groups and things of that nature. We do it with diabetes and diet plan matching. So it's not an it's not something that's hyper complex, but I think at this point, the guidance is moving toward making sure that those individuals are licensed at some level by the state so that you can have appropriate oversight, deploy them within specific clinics so that they can be a part of the team, and then they can run group huddles in that so that they can use the same vernacular, have the same interaction, and all be on the same page with what they're trying to help the patient with. And I think that that's the better way to deploy them. And who to deploy them to, it's probably everybody who just initiates into treatment should have access to a peer support to help guide them through the connected pieces. And then the other is for those that maintain at a high level of risk for relapse or overdose, and that can be spelled out within the literature. And that would be someone who's had an overdose, someone who lives in an unsecure environment, someone with unstable housing. Those are people who would benefit from that peer support. But as far as exactly what we have to do, with the peer support network and the group, I think we still have a lot of unanswered questions before they can be appropriately deployed at scale. And you had another question, Ron?
Sure. I'll go ahead and pipe in. Other folks will line up their questions. Last week, Ann Shields and I both did a webinar, one on chronic disease and the other one on bidirectional care, and the work that folks are doing in the region and in the community, and just a kind of a reminder about how this really fits into that work, and that my sort of encouragement to integrate what you're talking about here and the work of the opiate group there into the focus populations that the chronic disease element is asking for, and that is focusing on the complex care folks, particularly those with more than one chronic disease and mental health and substance use disorder, and the focus on diabetes. And maybe you could just say, give your perspective in terms of how they might integrate this work into work around focusing on particular populations like that, particularly people with diabetes. Is there anything in particular or special they need to think about?
Yeah, no, it's again a good question. So this is, I was very lucky for the last 2 years. I had this Robert Wood Johnson funded fellowship, basically digging into complex care. So it wasn't just around addiction. It was a lot of it really doing deep dives into that 5% and trying to find out what it is that we need to do to stabilize them. And one of the big issues was if we don't do a good job, and whether they have diabetes or hypertension, if we don't move up that ladder and do a deep dive assessment of, do they have one of the sentinel syndromes? Because if they do, quite honestly, you're never going to get that diabetes under control until you stabilize the addiction, the mental health piece, the chronic pain, or the cognitive disorder, or at least know that they have it. And what I mean by cognitive disorder is that subset of the population that may be on the spectrum, maybe low IQ, maybe have suffered a traumatic brain injury and have some cognitive deficits for onboarding new information or reacting to complex situations. Those are patients who you give them a set of discharge instructions or tell them to count their carbs. They're just not going to be able to do that. So if you don't identify those sentinel syndromes and then the associated issues that come with that, the homelessness, incarceration, and then that's the big issue. So really good upfront screening of those individuals who have difficult to control diabetes, COPD, asthma. Those are ones that you really want to dig down into the identification of those sentinel syndromes, and then really focus treatment on those, then really start to work on the really what comes out to be the effect of those uncontrolled syndromes, which is hyperglycemia, hypertension, or poorly controlled respiratory status.
Thank you so much for those questions and answers. We do have a couple more online that I'm going to ask real quick. Sarah Schumacher had a question. She said, when you mentioned that individuals may experience different education based on the program, will there be a push to have more uniform evidence-based programming related to IIP 3.5 to 3.7? If so, do you know of beneficial approaches or models?
Yeah, so it's, I think, just IP, inpatient 3.5 to 3.7.
Thank you.
Yeah, no, that's fine. And then but yes, so right now there is a work group at the national level with ASAM, NIDA, CDC, and the recovery community and the treatment community actually building out the specs of what a level 3 to level 4, everything on that in between, should be delivering as far as evidence-based criteria. And that means the behavioral therapies. What do we have evidence for? I mean, should everybody have access to, you know, equine therapy? You know, I mean, these are things that we have to fundamentally deal with. And there are evidence-based things that are not being delivered at some of the biggest programs in the country. And then there are also some evidence-based things not being delivered at the basic Medicaid level program. So it's all over the place. It's not, you know, one or the other. So that guidance is forthcoming. And I've been working really closely and we'll be coming on to, if things continue to progress, onto probably the editorial staff for the ASAM criterion. As we do that, we will be able to really specify out over time what does a quality program look like, so that you can just check the boxes and know that what you're paying for is high quality evidence-based work.
Thank you so much. We've got one more question I'm going to read off. Jessica Ochoa asked, do you have more information on the bill you mentioned regarding HIPAA?
Yeah, it's HR 5971. And basically what it does is it rolls addiction treatment information into HIPAA under the treatment planning and business operations. And you still need a specific release for outside of healthcare release of information. And it has the criminal justice protections added that Part 2 had added, so that we don't have people losing their kids because somebody pulled health information without there being cause. So those are, that's what had passed pretty handily in the House from there. And we've been working on that from the ASAM side for a while. And again, that's HR 5971.
Thank you so much, Dr. Waller. Do we have any other questions that people want to put in either through the chat box or just directly?
And you can also submit, you know, if you have other questions, just shoot an email off to the team, and I'll be happy to pull up some info for those things. But I would recommend, you know, reading over the ASAM criteria. There's some basic stuff, and then also TIP 63, Treatment Improvement Protocol 63 from SAMHSA, which is free to download the PDF of that, and that really does go through the most current evidence for opioid use disorder treatment.
All right, thank you so much. Well, we will have this webinar as well as the PowerPoint up on the web on our website as soon as we can. Thank you so much, Dr. Waller. That was really, really helpful and informative, so we really appreciate you taking the time. And again, if anyone has any follow-up questions, you can send those to us or directly to Dr. Waller, and we'll get you that information as soon as we can. So thanks, everyone, and we will give you 16 minutes of your day back.
Great. Thank you. Have a great day.